Basics of Medical Biochemistry. First edition, 2023. Chapter 11. Metabolism of Proteins and Amino Acids. Part 2 of 2. By Professor Dr. Muhammad Jawad. MBBS, Dow, M. Philosophy, PhD, Dip M.E. Head of the Biochemistry Department Faiz-i Ruthfa Medical College PAF Base Faisal Karachi Pakistan. Ex-Professor of Biochemistry, Qasim University Kingdom of Saudi Arabia. Ex-Professor, Head of the Biochemistry Department and Vice Principal. Liaquat College of Medicine and Dentistry and Fatima Jinnah Dental College, Karachi, Pakistan. 11.7.9 Metabolism of phenylalanine and tyrosine. Both phenylalanine and tyrosine are aromatic amino acids. Structurally, phenylalanine is alanine in which one hydrogen of CH3 is substituted with the phenyl group, while tyrosine is p-hydroxyphenylalanine, phenolic amino acid. Nutritionally, phenylalanine is an essential amino acid but tyrosine is a non-essential amino acid. They are mixed-function amino acids giving both glucogenic and ketogenic intermediates. Conversion of phenylalanine to tyrosine. Phenylalanine is converted irreversibly to tyrosine by phenylalanine hydroxylase. Phenylalanine hydroxylase is a mixed-function oxidase that uses the cofactor tetrahydrobiopterin to split molecular O2, adding one atom to the phenylalanine ring and converting the other to water. This reaction also needs NADPH+ to convert dihydrobiopterin back to tetrahydrobiopterin. Tyrosine synthesis occurs in the liver when the intake of tyrosine in the diet is low. In a diet low in tyrosine, as much as half the ingested phenylalanine may be converted to tyrosine in the body. Figure 11.13 Conversion of phenylalanine to tyrosine. Anabolic fates of tyrosine. 1. Synthesis of catecholamines, dopamine, norepinephrine, and epinephrine. Tyrosine is hydroxylated to dihydroxyphenylalanine, DOPA, by tyrosine hydroxylase, tyrosinase, which gives epinephrine and melanin. DOPA is decarboxylated to dopamine by aromatic amino acid decarboxylase. Pyridoxal phosphate, PLP, is the cofactor for this reaction. Hydroxylation of the side chain of dopamine produces norepinephrine by dopamine hydroxylase. Methylation of norepinephrine occurs by phenylethylamine and methyltransferase to give epinephrine. The S-adenosylmethionine is used as a methyl donor in this step. Figure 11.14 Synthesis of catecholamines, dopamine, norepinephrine, and epinephrine. 2. Synthesis of melanin. Melanin is the dark pigment formed from several compounds. Melanin synthesis begins in the liver where phenylalanine is converted to tyrosine by the action of phenylalanine hydroxylase. The oxidation of L-tyrosine to L-DOPA is then catalyzed by the action of tyrosinase, tyrosine hydroxylase, enzyme within the melanosome of melanocytes. Tyrosinase is a copper-requiring enzyme. In the next step, L-DOPA is oxidized to dopaquinone. From dopaquinone, the melanin synthesis pathways diverge to produce either eumelanin or phenylalanine. Melanin formation is stimulated by light, ACTH, and MSH. The presence of Zn2+ ions is essential for melanin synthesis. Melanin also plays a role in the development of optic nerves, so people with albinism have vision problems. Eumelanin. Firstly, dopaquinone is converted to leukodopachrome and then dopachrome through autooxidation, and subsequently in the presence of dopachrome tautomerase and dihydroxyindole 2-carboxylic acid oxidase, dopachrome is converted to 5,6-dihydroxyindole. Finally, the oxidation of 5,6-dihydroxyindole, DHI, to indole 5,6-quinone by tyrosinase leads to the formation of eumelanin, brown-black pigment. Phenylalanine. In the presence of cysteine or glutathione, dopaquinone is converted to cysteine-L-dopa. Subsequently, phenylalanine, a yellow-red pigment, is formed through the oxidative polymerization of cysteine-L-dopa via 1,4-benzothiazinylalanine intermediates. Figure 11.15 Synthesis of melanin pigments. 3. Synthesis of thyroid hormones. there are two biologically active thyroid hormones, i.e. 3,5,35-tetraiodothyronine, T4, usually called thyroxine, and 3,5,3-triiodothyronine, T3. Both of these are derived from the modification of tyrosine. Iodination of tyrosine, organification of thyroglobulin, is the main involvement of tyrosine in the formation of thyroid hormones. Iodine binds to 3 position in the tyrosyl ring, a reaction yielding 3-monoiodotyrosine, MIT. Subsequent addition of another iodine to 5 position of the tyrosyl residue on MIT creates 3,5-diiodotyrosine, DIT. The coupling of 2 DIT gives T4 or thyroxine, while the coupling of MIT and DIT gives rise to triiodothyronine or T3. For formation of the insulin receptor, tyrosine has a significant role in the construction of and working of many tyrosine kinases containing receptors such as insulin receptors. Catabolic fates of tyrosine. 1. Conversion into fumarate and acetoacetate, it is converted to fumarate, glucogenic, and acetoacetate, ketogenic, through homogentisic acid. 2. Putrefaction to phenol, it occurs by intestinal bacteria. Phenol is toxic and must be detoxicated by conjugation with phenyl sulfate. Tyramine produced during this process is vasoconstrictive. Metabolic disorders of phenylalanine and tyrosine. 1. Phenylketonuria, this is a congenital disease with 5 subtypes, due to complete to mild deficiency of phenylalanine hydroxylase or defective dihydrobiopterin synthesis. It causes an accumulation of phenylalanine in the blood. Alternative pathways for the oxidation of phenylalanine in the liver lead to the formation of phenylpyruvate, phenylactate, and phenylacetate. The latter is activated into phenylacetyl-CoA and conjugates with glutamate or glutamine as a detoxification reaction to give phenylacetyl-glutamate. These abnormal products increase in blood and appear in the urine. Figure 11.16 Catabolism of tyrosine. The following are the important features of phenylketonuria. Hyperphenylalaninemia, i.e., raised blood phenylalanine level. It is the most commonly occurring inborn error of amino acid metabolism, its incidence is 1:15,000. No sex specification. The mousy odor of urine is due to the presence of phenylacetyl-glutamate. Neonatal vomiting and mental retardation, due to deposition of phenylalanine and its toxic metabolites in the brain. Fair hair, light-colored skin, and blue eyes, hypopigmentation. Eczema of the skin. Skin is also sensitive to UV rays. EEG abnormalities and early fits of epilepsy. Diagnosis, by neonatal screening for increased levels of phenylalanine. Treatment, phenylalanine-restricted diet along with tyrosine supplementation in the diet. Treatment must be started from 7 to 10 days of life to prevent cognitive impairment. 2. Alkaptonuria, it is an autosomal recessive congenital deficiency of homogentisic acid oxidase that results in the accumulation of homogentisic acid and its appearance in urine. The following are the important features of alkaptonuria. As an alternative pathway, the accumulated p-hydroxyphenylpyruvate is converted into p-hydroxyphenylactate and p-hydroxyphenylacetate. In this condition, the urine is normal in color when freshly voided but readily changed to brownish-black colored pigment, alkapton, due to the oxidation of homogentisic acid by oxygen of the air, when the urine sample is left uncovered for some time. Prevalence is rare 1:250,000. Common in premature infants with a deficiency of vitamin C. Painful condition due to deposition of homogentisic acid in bones, cartilages and tendons, achronosis. Otherwise, it does not create any problems. Experimental alkaptonuria can be produced by alpha-dipyridyl administration. 3. Albinism. Albinism refers to a group of conditions in which a defect in tyrosine metabolism results in the reduced production of melanin. Albinism is caused by an alteration of the gene that makes melanin pigment. It is detected at birth because of irregular pigmentation. The most accurate way to determine albinism and the specific type is through genetic testing. It appears in different forms, and it may be inherited by one of several modes: autosomal recessive, primary mode, autosomal dominant, or X-linked. Albinism is associated with several vision defects, such as photophobia, nystagmus, and amblyopia. These optical defects occur regardless of the specific genetic cause of albinism. These defects result in the partial or full absence of pigment from the skin, hair, and eyes. The skin and eyes must be protected from the sun. Sunglasses, UV protected, may relieve photophobia. Complications include skin cancer, decreased vision, and blindness. Eye-complete albinism or oculocutaneous albinism, OCA. It is also known as tyrosinase negative oculocutaneous albinism, results from a deficiency of copper requiring tyrosinase, causing a total absence of pigment from the hair, eyes, and skin. It is the most severe form of the condition. There are several forms of oculocutaneous albinism. OCA1 results from a genetic defect in an enzyme called tyrosinase. OCA2 results from a genetic defect in the P protein. OCA3 is rarely described and results from a genetic defect in TYRP1. OCA4 results from a genetic defect in the SLC45A2, solute carrier family 45-member 2, protein. Figure 11.17 Patient with oculocutaneous albinism, source, healthjade.com. Table 11.3 Comparison between two types of oculocutaneous albinism. Tyrosinase positive. Tyrosinase negative. Some visual pigments are present. Hair bulbs can convert added tyrosine to pigment. Melanocytes contain lightly pigmented melanosomes. No visual pigment. Hair bulbs fail to convert tyrosine to pigment. Unpigmented melanosomes in melanocytes. 2. Partial albinism. Ocular albinism affects only the eyes, causing minimal pigmentation in them. The iris may appear translucent. It is caused by a change in the GPR143 gene that plays a signaling role that is especially important to pigmentation in the eye. Reduced visual acuity, nystagmus, and difficulty in controlling eye movements may occur in this condition. 4. Tyrosinosis, inborn error due to deficiency of p-hydroxyphenylpyruvate hydroxylase, fumaryl acetoacetate hydrolase, or mallyl acetoacetate isomerase. Normal plasma tyrosine levels are 30 to 120 mol/L. Values greater than 200 mol/L are considered elevated. In tyrosinosis, blood has high tyrosine levels and large amounts of p-hydroxyphenylpyruvate, p-hydroxyphenylactate, and acetate are excreted in the urine. It causes liver damage and death due to liver failure. Tyrosinemia type I. Characterized by excessive excretion of tyrosine and tyramine in urine. Deficiency of enzyme fumaryl acetoacetate hydrolase right from birth. The incidence rate is 15/10,000 births. Urine has a characteristic cabbage-like odor. In the acute form, symptoms manifest by the first 6 months of life and death occurs in many cases. In the chronic form, hepatic cirrhosis, nephropathy, and mental retardation may be observed. Tyrosine-restricted diet is advised. 2. Tyrosinemia type 2, Rich-Narhan-Hart syndrome. It is caused by a deficiency of the enzyme hepatic transaminase. Clinical features: mental retardation, dermatitis, eye lesions, and disturbance in fine coordination. Blood tyrosine level is elevated, greater than 500 mol/L. Urine: increased urinary concentration of tyrosine with other metabolites such as tyramine and N-acetyltyrosine. 3. Neonatal tyrosinemia. May be seen in premature infants. Deficiency of enzyme p-hydroxyphenylpyruvate hydroxylase, relative or transient. Elevated levels of tyrosine and phenylalanine in the blood. Increased urinary excretion of tyrosine, tyramine and p-hydroxyphenyl acetate. Treatment: a diet low in protein, tyrosine and phenylalanine, with supplementation of vitamin C. 4. Hereditary tyrosinemia. Uncommon hereditary disorder. Deficiency of enzyme p-hydroxyphenylpyruvate oxidase. Features are the same as of neonatal tyrosinemia, except for comparatively increased excretion of p-hydroxyphenylactic acid, and it is not suppressed by vitamin C. Usually, death occurs before age of 6 months, due to liver failure. If the child survives, then he develops nodular cirrhosis, proteinuria, aminoaciduria, hyperphosphaturia, increased tendency to develop hypoglycemia, hypophosphatemic rickets and hepatic carcinoma, as a late complication. 5. Pheochromocytoma. This is a benign tumor affecting the cells of the adrenal medulla. It overproduces mostly norepinephrine and to some extent epinephrine. The main symptoms are continuous or intermittent high blood pressure, palpitations, weight loss, sweating, flushing, numbness, headache, blurring of vision and chest pain. Death may occur due to pulmonary edema, cerebral hemorrhage, or ventricular fibrillation. November 7. 10. Metabolism of tryptophan. It is a heterocyclic, aromatic, and indole ring containing essential amino acids. It is both glucogenic and ketogenic in nature. Anabolic fates of tryptophan. Its anabolic products are nicotinamide, serotonin and melatonin. 1. Nicotinamide, niacin or vitamin B3. Niacin is an important nutrient. The liver can synthesize niacin from tryptophan. 60 mg of tryptophan can produce 1 mg of niacin. It is produced by the kynurenine anthranilate pathway. Riboflavin, vitamin B2, pyridoxine, vitamin B6, and iron are required for its synthesis. A deficiency of vitamin B2 leads to the formation of kynurenic acid, and a deficiency of vitamin B6 leads to the formation of xanthurenic acid. Zein, the main protein of corn, of maize, is deficient in tryptophan. Thus people depending on a corn diet deficient in tryptophan or niacin suffer from pellagra disease. Figure 11.18 Synthesis of niacin, serotonin, and melatonin from tryptophan. 2. Serotonin, 5-hydroxytryptamine or enteramine or thrombocytin. Tryptophan is hydroxylated by hydroxylase in the liver, and 5-hydroxytryptophan produced is decarboxylated in the liver, kidney, and stomach, argentophane cells of GIT, into serotonin. Other sites of serotonin synthesis are platelets, the retina, the brain, and mast cells. Normally 1% of tryptophan is changed into serotonin. But in carcinoid tumors, argentophanoma, 60% is converted into serotonin. Serotonin acts through specific serotonin receptors, which are a group of G protein-coupled receptors and ligand-gated ion channels found in the central and peripheral nervous systems. These receptors are found throughout the brain, particularly in areas of the limbic system, including the hypothalamus, hippocampus, septum, neocortex, and regions associated with motor behavior, including the substantia nigra and globus pallidus. The serotonin receptors are activated by the neurotransmitter serotonin, which acts as their natural ligand. Serotonin has multiple functions, including pain perception, regulation of sleep, appetite, temperature, blood pressure, cognitive functions, and attitude, which causes a feeling of happiness. The main biochemical roles of serotonin are CNS stimulator, cerebral activity and excitation, vasoconstrictor, regulation of blood pressure, smooth muscles contractor, bronchospasm and diarrhea, homeostasis, by platelets, and it also acts as an inducer of apoptosis. A deficiency of serotonin has depressant effects. Regular exercise along with the intake of food rich in tryptophan can positively impact serotonin levels in the brain. Clinical aspect: argentophanoma or carcinoid tumor is a condition characterized by excessive production of serotonin. The main clinical features are cyanosis, chronic diarrhea, cardiac problems, and bronchospasm. It is diagnosed by the determination of 5-hydroxyindole acetic acid in a 24-hour urine sample. Treatment is by p-chlorphenylalanine, an inhibitor of tryptophan hydroxylase. LSD, lysergic acid diethylamide, an extremely potent hallucinogen, is supposed to do its action by inhibiting the normal actions of serotonin on CNS. 3. Melatonin, N-acetyl-5-methoxyserotonin. It is considered the youth hormone. It is secreted by the pineal body and peripheral nerves. Melatonin is derived from serotonin by acetylation followed by O-transmethylation. The methylation reaction is localized in pineal body tissue. Serotonin N-acetylase is the rate-limiting enzyme. Its synthesis and secretion have diurnal variations controlled by the light sleeping cycle. It circulates in the blood and is taken up by all tissues including the brain. Melatonin has the following functions. It has a strong antioxidant and anti-cancer effect. It has a regulatory effect on the sleeping cycle and the biological clock. It appears to depress the gonadal function and may mediate the light-induced seasonal reproductive cycles. It lightens skin color in lower animals, example frogs. It is excreted through urine after hydroxylation at C6 and conjugation with sulfate or glucuronic acid in the liver. Catabolic fates of tryptophan. 1. Putrefaction of tryptophan. Large intestinal bacteria putrefy tryptophan into indole and scatole. Indole and scatole pass with feces and give the characteristic odor of the stools. This is the normal fate of indole, but during constipation, it is reabsorbed by intestinal mucosa to be hydroxylated into indoxal that is conjugated with active sulfate in the liver and then excreted in urine as potassium indoxal sulfate, indican. Therefore, indican is one of the abnormal constituents of urine, where it is a marker for constipation or increased putrefaction in the intestine or putrefaction in large abscesses somewhere in the body. 2. Formation of indole acetate or lactate. Tryptophan is also transaminated or oxidatively deaminate into indole pyruvate that is reduced into indole lactate or decarboxylated into indole acetate. 3. Formation of acetoacetate. The main catalytic pathway for tryptophan carbon skeleton is through kynurenine to acetoadipate that gives acetoacetyl CoA, ketogenic. This pathway starts with tryptophan oxygenase, a liver enzyme inducible by tryptophan and adrenal cortical hormones. Kynureninase requires pyridoxal phosphate, PLP. A deficiency of vitamin B6 leads to a shift of 3-hydroxykynurenine into xanthurenate by deamination. The appearance of xanthurenate in urine is used as a marker for vitamin B6 deficiency. Vitamin B6 deficiency leads also to nicotinic acid deficiency because it is synthesized from tryptophan by the 3-hydroxyanthranolate pathway. Metabolic disorders of tryptophan. Hartnup disease. It is also known as pellagra-like dermatoses. It is an autosomal recessive metabolic disorder affecting the absorption of nonpolar amino acids, particularly tryptophan, that can be, in turn, converted into serotonin, melatonin, and niacin. It results from defects in the intestinal and renal transport of neutral amino acids including tryptophan. It is belonging to the neutral amino acidureas and is characterized by defective sodium-dependent and chloride-independent neutral amino acid transporter, expressed predominantly in the kidneys and intestine. Most subjects remain asymptomatic. Symptomatic subjects usually present with skin photosensitivity, pellagra-like skin eruption, neurological symptoms, cerebellar ataxia, trembling, headaches and hypotonia, psychiatric symptoms, anxiety, emotional instability, delusions and hallucinations, and aminoaciduria. Ocular manifestations like double vision and photophobia may also occur. November 7, 11 Metabolism of the branched-chain amino acids. These are essential amino acids and include isoleucine, leucine, and valine. Catabolism of the branched-chain amino acids. These are metabolized primarily by the peripheral tissues, particularly muscle, opposite to other amino acids which are metabolized by the liver. They follow the same route of catabolism, that's why they are described as a group. They undergo the following reactions. 1. Transamination. Removal of the amino groups of all three amino acids is catalyzed by a branched-chain amino acid aminotransferase in the presence of pyridoxal phosphate, PLP. 2. Oxidative decarboxylation. Removal of the carboxyl group of the alpha-keto acids derived from leucine, valine, and isoleucine is catalyzed by a single multi-enzyme complex, called branched-chain alpha-keto acid dehydrogenase complex. This complex requires many coenzymes like thiamine pyrophosphate, TPP, lipoic acid, FAD, NAD+, and CoA. 3. Dehydrogenation. Oxidation of the products formed in the above reaction yields alpha-beta unsaturated acyl CoA derivatives. The nature of this reaction is similar to the FAD-linked dehydrogenation taking place in the beta oxidation scheme of fatty acid catabolism. Finally, the catabolism of valine yields succinyl-CoA and is glucogenic. Isoleucine yields acetyl-CoA and succinyl-CoA, confirming that it is both ketogenic and glucogenic. Leucine is ketogenic, as metabolized to acetoacetate and acetyl-CoA. Clinical aspects: maple syrup urine disease, MSUD. An inherited deficiency of branched-chain alpha-keto acid dehydrogenase results in the accumulation of the branched-chain alpha-keto acid substrates in the urine. Urine has a characteristic odor of maple syrup or burnt sugar, which prompted the name maple syrup urine disease. Prevalence is rare at 1:185,000 as an autosomal recessive disorder. The disease becomes evident in the first week of life. The infant does not take feed, vomits and is lethargic. Neurologic problems are common. The disease has a high mortality rate. This disease is treated by special purified amino acid formula that has a low amount of branched-chain amino acids. November 7, 12 Metabolism of histidine. It is an indole ring containing basic amino acids and is considered essential in growing children. Histidine is frequently found in the active sites of enzymes, where the imidazole ring can bind and release protons during enzymatic reactions. It is glucogenic in nature and involved in glutamic acid formation. Figure 11.19 Catabolism of histidine. Histidine is a source of one carbon compound for many reactions in the body. It is the precursor of a very important amine, i.e., histamine. It is changed into histamine by histidine decarboxylase. Histidine-histamine. Figure 11.20 Formation of histamine from histidine. Histamine is produced in the intestine by bacteria and secreted by mast cells after trauma or allergic reactions. The cellular responses of histamine include allergic reactions as evident by urticaria and laryngeal edema, in severe cases. Inflammatory reactions and injection of histamine in the skin exhibit triple response. Bronchoconstriction, particularly in patients with bronchial asthma. Gastric secretion, via H2 receptors. Neurotransmission in the brain. Vasodilation leads to a fall in both systolic and diastolic blood pressure. Histamine is inactivated by methylation to methylistamine by the enzyme histamine N-methyltransferase and then oxidation to N-methylimidazole acetic acid by the enzyme monoamine oxidase, MOA. It is also inactivated by diamine oxidase, DAO, to imidazole acetic acid. Antihistamines are important anti-allergic agents. Clinical aspect: histidinemia is a rare hereditary metabolic disorder characterized by a deficiency of the enzyme histidase. The concentration of histidine is elevated in the blood and urine. Prevalence is 1:180,000. Mental retardation is common. November 7, 13 Metabolism of sulfur-containing, methionine, cysteine and cysteine, amino acids. Methionine is nutritionally an essential amino acid and can be produced from homocysteine in the body. Cysteine and cysteine, dicysteine, are interconvertible in the body by the removal/addition of two hydrogens catalyzed by cysteine reductase. They are glucogenic, sulfur-containing, and non-essential amino acids synthesized in the body from methionine, as homocysteine, coupled with serine. Anabolic fates of sulfur-containing amino acids. Synthesis of proteins, particularly scleroproteins and certain hormones, example insulin and vasopressin. Synthesis of glutathione, a tripeptide of glutamic acid, cysteine, and glycine. Synthesis of cysteine, two molecules of cysteine give cysteine. Figure 11.21 Interconversion of cysteine and cysteine. Detoxification: cysteine, as it reacts with aromatic compounds, example benzene, polycyclic hydrocarbons like naphthalene and ring halogenated hydrocarbons, example bromobenzene, that is then acetylated and excreted in the urine. Functions of methionine: it acts as a methyl donor, involved in the synthesis of cysteine and then cysteine. It undergoes two principal metabolic pathways: transmethylation, formation of homocysteine, and transsulfuration, formation of cysteine. Formation of homocysteine: methionine is first changed into S-adenosylmethionine by methionine adenosyl transferase. Methionine plus ADP S-adenosylmethionine plus PPI plus pi. S-adenosylmethionine is converted to S-adenosylhomocysteine after the removal of the methyl group by the enzyme methyltransferase. S-adenosylhomocysteine is then hydrolyzed to homocysteine and adenosine by S-adenosylhomocysteine hydrolase. S-adenosylhomocysteine plus H2O homocysteine plus adenosine. Homocysteine is now converted to methionine by methionine synthase in the presence of vitamin B12. Homocysteine plus N5-methyltetrahydrofolate methionine plus tetrahydrofolate. Formation of cysteine. When methionine is adequate in the body, the homocysteine is converted to cysteine. Homocysteine is condensed with serine to form cystathionine by the enzyme cystathionine beta synthase. Cystathionine is then hydrolyzed to cysteine by gamma-cystathionase. NH3 and alpha-ketobutyrate are also produced in this reaction. Both of these reactions occur in the presence of pyridoxine, vitamin B6. In this process of transsulfuration, the sulfur of methionine becomes the sulfur of cysteine. Serine H2OH2ONH3 plus alpha-ketobutyrate. B6B6. Homocysteine cystathionine cysteine. Alpha-ketobutyrate is converted to propionyl-CoA by oxidative decarboxylation, and propionyl-CoA is then converted to succinyl-CoA. Clinical aspect: normal homocysteine levels in the blood is 4 to 15 mol/L. Any measurement above 15 is considered high. A high level of homocysteine is a risk factor for heart disease. Increased levels of homocysteine in the blood can damage the lining of the arteries. High levels may also make the blood clot more easily. This can increase the risk of blood vessel blockages. It is associated with low levels of vitamins B6, B12, and folate, as well as renal disease. However, studies have shown that reducing homocysteine levels with vitamins does not reduce the chance of having heart disease in established cases. High homocysteine and low folic acid levels in the blood of pregnant women are associated with increased chances of neural tube defects, birth defects of the brain, spine, or spinal cord. Catabolic fates of sulfur-containing amino acids. Cysteine is regarded as the major source of inorganic sulfate in the body. Sulfate is used for sulfation reactions after activation into 3-phosphoadenosine 5-phosphosulfate, active sulfate or PAPS, catalyzed by sulfotransferase. 2-ADP plus SO42 rightward arrow PAPS plus ADP plus PPI. Sulfate detoxifies phenol or indole into phenyl sulfate or indoxyl sulfate, indican, respectively, that go to urine. Sulfated steroids and sulfated sugar derivatives are also produced by sulfation with PAPS. Cysteine is transaminated in the presence of vitamin B6 into beta-mercaptopyruvate. Desulfhydrase converts cysteine into pyruvate, H2S, and ammonia by non-oxidative deamination. Cysteine is decarboxylated into mercaptoethanolamine, a part of coenzyme A, by decarboxylase and PLP. Thiosulfate produced from cysteine is used for the detoxification of cyanide into thiocyanate and sulfite. HCN plus Na2S2O3 rightward arrow HCNS plus Na2SO3. Metabolic disorders of sulfur-containing amino acids. 1. Cystinosis, cysteine storage disease. It is a lysosomal genetic disease characterized by the deposition of cysteine crystals in many tissues, especially the reticuloendothelial system, due to defective carrier-mediated transport of cysteine. It is due to impaired conversion of cysteine to cysteine. It is accompanied by impaired renal function and generalized aminoaciduria. The patient dies at a young age from acute renal failure. This condition is diagnosed by the detection of cysteine in the cornea by slit lamp microscopy. 2. Cystinuria, cysteine lysinuria. It is one of the most common inherited diseases, 1:7000, as well as the most common genetic error of amino acid transport. It is characterized by a marked increase in urinary cysteine, 20 to 30 times normal, together with basic amino acids, lysine, arginine, and ornithine. It is due to defective renal tubular reabsorption of these four amino acids, chol, cysteine, ornithine, arginine, lysine, with possible formation of cysteine stones. It is managed significantly by oral hydration. 3. Homocystinuria. It is an inborn error of the catabolism of methionine. It is caused by a genetic deficiency of the enzyme, cystathionine beta synthase. There is an increased plasma level of homocysteine and increased urinary excretion with low plasma levels of cysteine. Incidence is 1 per 60,000 live births. The main clinical features are mental retardation, affected individuals who are extraordinarily tall with flat feet, thrombosis, the main cause of early deaths, hepatomegaly and skeletal deformities like codfish vertebrae. It is treated by restriction of methionine and supplementation of vitamin B12 and folic acid. Figure 11.22 Metabolism of sulfur-containing, methionine, cysteine and cysteine, amino acids. November 7, 14 Metabolism of arginine. It is a non-essential, but essential in children, and glucogenic amino acid. It takes part in the urea cycle directly and split up to give urea and ornithine. It participates in the formation of creatine, polyamines, via ornithine, and nitric oxide, NO, i.e., free radical gas as neurotransmitters. Arginine gives nitric oxide by the enzyme nitric oxide synthase in the presence of O2 and NADF. L-arginine nitric oxide, NO, plus citrulline. The synthesis of NO occurs in response to a stimulator binding to a receptor on some cells or a nerve impulse in neurons. Nitric oxide enters smooth muscle cells, stimulating guanylate cyclase to produce cGMP, which causes smooth muscle cell relaxation and blood vessels to dilate. It also prevents platelet aggregation and is metabolized spontaneously to nitrites and nitrates. November 7, 15 Metabolism of proline. It is an alpha amino acid rather than alpha amino acid. Formation of cross-links in collagen. Hydroxyproline residues are involved in hydrogen bond formation that helps to stabilize the triple helix of collagen molecules. During the synthesis and maturation of collagen, selected lysine and proline are hydroxylated. This process needs ascorbic acid, vitamin C, as a cofactor. The hydroxylation of lysine and proline is carried out by the enzymes lysyl hydroxylase and prolyl hydroxylase respectively. These modified forms of proline and lysine as 4-hydroxyproline and 5-hydroxylysine are critical for maintaining connective tissues. November 7, 16 Metabolism of lysine. It is an essential amino acid, basic and ketogenic in nature. It gives rise to acetyl-CoA. Lysine is involved in the formation of histone, hydroxylysine, and carnitine. Hydroxylysine is found in many structural proteins, example collagen, as a result of a post-translational modification. Table 11. 4 amino acids and fates of their carbon skeleton. Amino acid. Fate of carbon skeleton. Asparagine. Oxalostate. Glutamine. Proline. Arginine. Histidine. Alpha-ketoglutarate via glutamate. Alanine. Serine. Glycine. Cysteine. Threonine. Pyruvate. Phenylalanine. Tyrosine. Fumarate. Methionine. Valine. Isoleucine. Threonine. Succinyl-CoA. Tryptophan. Leucine. Isoleucine. Lysine. Acetyl-CoA. Summary. Nitrogen enters the body as dietary protein and leaves the body as urea, ammonia, creatinine, etc. The rate of protein turnover is approximately 300 to 400 grams daily. The primary role of protein is to provide amino acids for the synthesis of tissue proteins and secondary as fuel. Amino acids are produced in the body as a result of the digestion of dietary protein, desquamation of body proteins, and by de novo synthesis of nutritionally non-essential amino acids. Amino acids are catabolized in 2 phases. 1st phase is the removal of the amino group as NH3 by transamination and deamination reactions. In second phase, the carbon skeleton of amino acids is metabolized in energy-producing metabolic pathways to produce CO2, H2O, glucose, fatty acids and ketone bodies, etc. Transamination is the transfer of the amino group, NH2, from an amino acid to a keto acid and the keto group from a keto acid to amino acid. Two clinically important aminotransferases are AST and ALT, both are raised in all hepatic disorders and they are useful in screening tests. Deamination is the removal of an amino group from amino acid as NH3 with the formation of its corresponding keto acid. Normal protein intake is 90 g/day, of which nitrogen forms about 16% of protein. Normally an adult person with a normal adequate diet is in a state of nitrogen equilibrium, i.e., nitrogen intake equals nitrogen loss. A significant amount of ammonia is produced in different body tissues from the catabolism of amino acids by deamination and deamidation reactions. Normal blood ammonia level is 18 to 60 μg/dl. The major biological role of the urea cycle is the detoxification of ammonia. Normal blood urea level is 20-40 mg/dl. Glutamine acts as a carrier of NH3 from various tissues of the body to the liver, where NH3 is detoxified to urea. The formation of glutamine in the brain prevents the accumulation of NH3. Phenylalanine is converted irreversibly to tyrosine by phenylalanine hydroxylase. Anabolic fates of tyrosine are catecholamines, dopamine, norepinephrine and epinephrine, melanin and thyroid hormones. Inborn errors of metabolism are a group of disorders, each of which involves a disorder of a single unique enzyme, genetic in origin and operating from birth. Phenylketonuria is a congenital disease due to a complete to mild deficiency of phenylalanine hydroxylase or defective dihydrobiopterin synthesis. It causes an accumulation of phenylalanine in the blood. Alkaptonuria is an autosomal recessive congenital deficiency of homogentisic acid oxidase that results in the accumulation of homogentisic acid and its appearance in urine. Albinism is a congenital defect in tyrosine metabolism that results in a deficiency in the production of melanin. Anabolic fates of tryptophan are nicotinamide, serotonin and melatonin. Hartnup disease is an autosomal recessive metabolic disorder affecting the absorption of nonpolar amino acids, particularly tryptophan. Normally 1% of tryptophan is changed into serotonin. But in carcinoid tumor, argentophenoma, 60% is converted into serotonin. Argentophenoma or carcinoid tumor is a condition characterized by excessive production of serotonin. The main clinical features are cyanosis, chronic diarrhea, cardiac problems, and bronchospasm. Maple syrup urine disease, MSUD, is an inherited deficiency of branched-chain alpha-keto acid dehydrogenase that results in the accumulation of the branched-chain alpha-keto acid substrates in the urine. Histidine is changed into histamine by histidine decarboxylase. Homocystinuria is an inborn error of catabolism of methionine. A high level of homocysteine is a risk factor for heart disease. References. Exercise questions. For MCQ 1 to 5, see Part 1 of this chapter. MCQ 6. A 3-year-old boy presented with progressive generalized edema. He was afebrile and his blood pressure was normal. Blood reports showed decreased serum albumin, increased serum cholesterol and normal blood urea. He was advised urinalysis test for further evaluation. Which of the following is the rate-limiting enzyme for the synthesis of the substance that was found normal in the blood of this patient? Arginase. Argininosuccinase. Argininosuccinate synthetase. Carbamoyl phosphate synthetase I. Ornithine transcarbamylase. MCQ 7. A 60-year-old woman suffering from multiple endocrine neoplasias, MEN, was brought to the hospital for the final diagnosis and treatment. History and clinical features are suggestive of carcinoid tumors. Which of the following amino acids has abnormal metabolism in this patient? Alanine. Phenylalanine. Tryptophan. Tyrosine. Valine. MCQ 8. A 2-year-old girl is noted to have white hair, including eyelashes and eyebrows. Her father has many of the same characteristics. Defect of which of the following enzymes is the likely cause of symptoms in this patient? Arginase. histidase, hydrolase, transaminase, tyrosinase. MCQ 9. 2 days after term normal delivery, a neonate begins to hyperventilate, develops hypothermia and cerebral edema and becomes comatose. Urinalysis revealed high levels of glutamine and orotic acid. The blood urea nitrogen, BUN, was below normal. Which of the following enzymes is deficient in this child? Cytoplasmic arginase, cytoplasmic carbamoyl phosphate synthetase, cytoplasmic orotitolate decarboxylase, mitochondrial carbamoyl phosphate synthetase, mitochondrial ornithine transcarbamolyase. MCQ 10. A 21-year-old man presented with chest deformity as a caved-in appearance of the breastbone. He has long, spindly arms and legs. His IQ level was below normal and the homocysteine level in his blood was raised. Which of the following amino acids is the source of the substance that is raised in this patient? Cysteine, glycine, methionine, tyrosine, valine. Please write answers in the comments or contact drmjot@yahoo.com. End of Part 2 of 2 of Chapter 11. Thank you.